Very, very good evening, sir. I was just telling Rajesh that you send your please new CV also.
Yeah.
We will send Bansi. Right. So thank you very much. I like to thank Dr. Manoj and entire team for inviting me for this centenary celebration of insulin. My slides are visible.
Very much.
Okay, thank you very much. So you have listened about insulin initiation, and Dr. Das has actually focused basically about barriers of insulin initiation, how to overcome those barriers of insulin initiation. And to me, over the years, so many years now, virtually, I have learned, and as last comment by Jaideep, actually, to me, patients are never a barrier to insulin initiation. It is doctors who are actually the biggest barrier to initiation. And if we still conduct a throughout country study, doctors have their unsaid barriers for initiating insulin therapy, and there lies actually the role of conducting all these CME programs, so that at least first we can make our own colleagues understand the importance of initiating insulin therapy right in time. Having said this, I have no conflict of interest, and this is briefly the agenda which I am going to discuss. You have listened that insulin has to be initiated. But when we see our patients of type 2 diabetes,
how much you're giving plain in the morning we give?
Sir, Dr. Das, sir, please mute yourself.
Sorry.
So when we see patients of type 2 diabetes, the first question often which comes to our mind is, when will most patient need insulin therapy? Now this is taken from UKPDS. And if you focus at year 0, that is when diabetes is diagnosed, already more than 50% of the beta cells are lost. And those who are practicing diabetes, large number of them actually are seeing patients whose diabetes duration is more than 6 to 10 years of duration, which means more than 70 or 80% of the beta cells are lost. And if we understand the natural history of type 2 diabetes, where it does not have therapies which can actually change the natural history of progression, then probably most people will need insulin therapy at some point of their natural history of type 2 diabetes. Also, it needs to be understood that maximum effectiveness of oral drugs is seen at half the maximal marketed dose. There is no point in giving glimepiride, gliclazide, glibenclamide, whatever drugs we are using in 3 times, 4 times, 20 milligrams a day. Hardly we can achieve the efficacy as far as glucose lowering is concerned when the dose is more than half the maximal. And then, before I come to the topic, why late initiation and intensification is harmful. Now you have initiated, it is not, question is not only initiation. As I have told you, diabetes is a lifelong disease. And after initiation, and as the current consensus goes on, patients are initiated with insulin therapy on a safe dosage, because we are not going to harm the patient. This is what we have been learned in our medical schools. So once patients are initiated, they have to be followed and their insulin has to be intensified. Apart from that, as diabetes is going to progress with the time over the year, even your initial insulin therapy, which is effective now, may not be effective 1 year, 2 year down the line. So again, patient need intensification, which means intensification is a lifelong process with our patient. We have to be patient and the doctor are to be in continuous touch with each other so that timely intensification is done. And by doing timely intensification only, we can bring HbA1c to less than 7%. And if this is not done in time, this I have taken from VADT, this is an extrapolation, we will generate lots of bad legacy effect. And there is no point, once patient has lived with poor glycemia for 5 to 10 years, then whatever costly forms of therapy we are going to use, it is not going to benefit patient in the same way. So friends, intensification is a continuous lifelong process of our type 2 diabetes. When we initiate, we have to also teach our patient about the importance of continuous follow-up and intensification of the therapy accordingly as the time goes on. It should not be that it has been initiated now and then patient forgets, doctor forgets, and he'll end up with complication. And why I am saying so with so much of power, that if you see, if we are not able to maintain HbA1c less than 7% over a long period of time, it will result in microvascular complication, macrovascular complication, and we often forget that overall, when these complications develops, the cost of diabetes management increases. It is 22% higher when patient has not developed any complication, which means we have to intensify in a time. Not only that, we have to understand, in last lecture, it has been discussing that basal insulin therapy in majority of guidelines is currently recommended as a therapy of choice for initiation. But if you see data which are published recently, only 30% of the patient with type 2 diabetes on basal insulin actually achieve an HbA1c of less than 7%. So it is good in a percentage of patient, but it is not good in always all type of patient. Not only that, once it has been initiated, it has to be intensified. And the reason is we have number of ways to intensify. And overbasalization, this is a very recent paper published in 2019 in Diabetes, Obesity and Metabolism, that overbasalization is a concern. Now, what do we mean by overbasalization? In this study, they have studied patients of type 2 diabetes, tried to find out as dose of basal insulin keeps on increasing, the amount of glucose lowering effect. But this glucose lowering effect of increasing basal insulin dose is not linear. In this study, they have shown that up to 0.3 unit per kg, there is a marked reduction in fasting plasma glucose. But as we move from 0.3 to 0.5, the effect of basal insulin on glucose lowering decreases. And beyond 0.5, as you see, when we move to 0.6 and 0.7, hardly there is any difference in glucose lowering. What basal insulin is adding is weight gain, the risk of hypoglycemia. So the basal insulin dosage of more than 0.5 international unit per kg per day have decreased impact on glucose lowering, but at the same time, it brings the disadvantage of weight gain as well as hypoglycemia. Therefore, if you are initiating with basal insulin therapy, the clinician should understand that you have to switch to a different form of insulin therapy, which we will be discussing in brief, once you are approaching a dose of 0.5 international unit per kg per day. So to conclude this part of the talk, when to stop basal insulin therapy if you have initiated with basal insulin therapy, when HbA1c is still not at goal with a dose of 0.5 unit per kg per day. And I have told you the basis behind that. When you have continuous HbA1c more than 7%, despite your fasting plasma glucose coming into the target, which means it's time we should target postprandial glucose. Next, when you're trying to increase basal insulin, but patient is experiencing nocturnal hypoglycemia, which means further increase in basal insulin is probably not going to help. So these are the scenarios where we should shift from basal insulin to some other insulin, or we should intensify to some other. Now, coming to the intensification, what are the options for intensification? Now, as I've told you, while discussing after the first lecture, there are a number of ways we can initiate. We can initiate with basal insulin therapy. We can initiate with once a day premixed insulin therapy, or we can initiate with twice a day premixed insulin therapy, or in a subset of patients like pregnant individuals or women, or like patients who are having on steroid therapy, having predominantly postprandial hyperglycemia, we can initiate with prandial insulin. And if your glucose levels are not coming into target, we have to intensify from this initiation regime. So there are a number of ways. From basal insulin, we can go to basal plus, basal bolus, twice mix, daily premix insulin therapy, insulin co-formulation therapy. So there are a number of ways by which we can intensify. And a new way to intensify the insulin therapy, if we are using injectable, is giving basal insulin along with GLP-1, which we will address very briefly at the end of this lecture. So there are a number of ways by which we can intensify from initiating insulin therapy. Now let's go to the next part of the lecture. As I have told you, there are a number of ways to achieve it. And obviously, if you see the literature, basal bolus is considered as a gold standard, but unfortunately, it is associated with at least 4 pricks in a day. brings lots of inconvenience, lots of monitoring, and is not accepted well by the patients. Physicians are not much conversant. So we have to find out an alternative solutions to that. And in Indian scenario, from basal insulin, intensification to with premix or with co-formulation is one of the ways. So if you see your patient who has been initiated on initial basal insulin therapy, you can go to an intensification with premix or with co-formulation. Now, in next part of my lecture, I am going to briefly discuss about a co-formulation, which is IDAC-ESP. Now, what is difference between premix and a co-formulation? Now, if you see, co-formulation is a preparation where two components of the insulin, that is basal component and rapid acting component, maintain their distinct identity. In contrast, in a premixed insulin, they are mixed with each other. The result is a cloudy mixture. In contrast, a co-formulation is a clear mixture. And a big advantage, as we are going to discuss a real world study, that you have to resuspend a premixed preparation in contrast to a co-formulation where resuspension is not needed. And PK/PD of individual insulin components are well preserved in co-formulation. However, because of the prendial component, even the half-life or end of the life of basal component is somewhat altered with premixed components. It is not only that insulins are available only as a co-formulation. There are co-formulation of basal insulin with GLP-1 RAs, that is degludec plus liraglutide and glargine plus lixisenatide. As I have told you at the end of the lecture, I will briefly discuss because this is another way to intensify the insulin therapy. Now coming to IDAC-ESP particularly, which I will like to discuss, this is a trial which is published again in 2019 in Diabetes Research Clinical Practice, where use of IDAC-ESP initially as OD and then BD is compared with basal bolus insulin therapy. The basal insulin used here is glargine and the short-acting insulin used is aspart. At week 26, this study has shown that with use of IDAC-ESP twice a day as compared to basal bolus insulin therapy, there is an identical similar 1.1% HbA1c reduction. But then what is difference? The difference is 12% lesser dose of insulin requirement, lesser risk of hypoglycemia to the tune of 45%, and this can be done in a single pen where insulin need not to be resuspended, in contrast to 4 injections in a day, which means it will also improve patient compliance as well as acceptance and also provide confidence to the physicians to find out a newer way to intensify insulin therapy rather than to remain dependent on basal plus therapy. Now, next, I would like to discuss about an ARISE study. I do not know how many of us actually have known about this study. This is a real world study with IDAC-ESP. Now, here, patients of type 2 diabetes, 1112 were the total number. They were given IDAC-ESP as per local practice. And this is a very recent presentation in August 2021. And this is a multi-country study involving Australia, India, Malaysia, Philippines, Saudi Arabia, and South Africa. Key inclusion criteria were physician's decision to start IDAC-ESP, age more than 18 years, patients who were diagnosed with type 2 diabetes, treated with any anti-hyperglycemic agent other than IDAC-ESP with an HbA1c available. And the study continued for 26 weeks. If we see the baseline characteristic of this study, this is almost identical to what we see in real world practice here, even in India, because India is also a part. Mean duration of diabetes is 13 years. Patients have a BMI of around 21 and with an HbA1c of 9.8%. If we see the previous anti-hyperglycemic treatments, 35% of the patients are only receiving OADs. 22% of the patients were receiving basal insulin therapy. 8% of the patients are receiving GLP-1 RA. 13% of the patients are on basal bolus insulin regime. And around 22% of the patients are premixed insulin therapy. If we see the frequency in which IDEC-SP is prescribed in ARISE study, 52.2% of the patient prescribed it as a once daily dose, and around 47.6% of the patient prescribed it as a majority of physicians have given the response, which means despite on number of therapies, their glucose is not in control. The risk, they want to minimize the risk of hypoglycemia and fewer injections than basal bolus therapy. To me, this is very important. No reconstitution is needed. Again, large number of physicians have given their response that they. So if you see the effect as per country, in Indian cohort, HbA1c has been lowered by 1.6%, in Saudi Arabia by around 2%, but overall if we see anywhere from 1.3 to 1.5% is a general lowering of HbA1c when patient is already on different type of insulin regimes. Their HbA1c is not under control, which means we need intensification. Now, if we see according to the treatment subgroup, which patient is receiving at baseline and when IDEC-SP is initiated, in those patients who are on OADs only, when IDEC-SP is initiated, HbA1c is lowered by around 2%. What Dr. Panikar was trying to tell that in India with prandial component too high in our meals, probably premix might be a better option as compared to basal. And if we see basal bolus therapy patient, those who are on basal bolus insulin therapy with HbA1c not controlled, when their insulin is intensified with IDEC-SP, an additional 0.9% lowering of HbA1c is concerned. What is important is that significant reduction in HbA1c from baseline is seen irrespective of the baseline treatment when HbA1c is not in goal and the treatment is initiated and intensified with IDEC-SP. If we see resource utilization, now this is very important, especially in our country, where we often only talks about the cost of the drug therapy. But then what about the cost of visiting patient to the hospital, visit to emergency room department, loss of work days, loss of wages, cost of commuting from one place to other. In this study, they have shown that with IDEC-SP, there is a marked reduction in resource utilization once patient is initiated on IDEC-SP. Coming to hypoglycemia, first, non-severe hypoglycemia, as you see clearly, these are the basal therapies. Once IDEC-SP is given instead of the baseline therapy, there is a reduction in non-severe hypoglycemia, and it is not only non-severe hypoglycemia. If you see, severe hypoglycemia is markedly reduced. So what is the aim of diabetes treatment? Aim of the diabetes treatment is not only HbA1c control, but achieving control of HbA1c without subjecting the patient to the risk of hypoglycemia. So the ARISE study, which is a real-world study, multi-country study, where initiation and intensification with a switch to IDEC-SP has been done, has shown that there is an effective HbA1c reduction to the tune of 1.6% in Indian cohort. There is an effective fasting plasma glucose control by around 52 milligram per deciliter in Indian cohort. There is an improved safety in terms of reduced non-severe as well as severe hypoglycemia, and there is a better resource utilization, which means significant reduction in outpatient visit as well as self-reported workday missed. So all outcome parameters, right from therapy efficacy to quality of life, are probably improved in ARISE study. Coming lastly to the agenda, that there is also other ways, as I have told you. It is not only that when patient is not controlled with basal insulin therapy, we have to only now go to premixed insulin therapy or basal bolus insulin therapy. Now we are moving into an era where we can add GLP-1 RAs to insulin therapy, and I have discussed there is a combination of degludec with liraglutide and glargine with lixisenatide. The beauty of these combinations of basal insulin and GLP-1 RA, that by giving once a day administration, we are targeting both fasting plasma glucose and postprandial. At the same time, with use of GLP-1 RA, weight gain associated with insulin therapy is counterbalanced. So this is one of such study where effect of insulin glargine up titration versus insulin deglutide and liraglutide is compared in patients of type 2 diabetes whose HbA1c is not in target. And this is dual 5 study. There is another study where IDAC-ASP is compared with basal bolus insulin therapy in dual 7 study. Now in dual 5 study, it has been observed that there is a significant reduction in HbA1c, and as you see, confirmed hypos as well as nocturnal hypos are reduced significantly with a weight loss of around 3.8 kg. At the same time, insulin dose is reduced by 38%. I am more interested in showing you the data of IDAC lira compared with basal bolus insulin therapy. Now here, as you see again, clearly HbA1c is non-inferior, almost similar degree of glucose control. But if you see the advantages, 90% reduction in confirmed and nocturnal hypo. There is a weight loss of around 3.6 kgs, and insulin dosage is reduced by more than 50%. So friends, we are in an era where there are more than one ways to intensify insulin therapy. And on 14th of this month, we are going to have an oral GLP-1 RA. So probably those patients who are initiated on basal insulin therapy not coming under control, we are going to find out a new way to intensify, where now we are going to have a oral GLP-1 RA to be used along with basal insulin therapy to intensify treatment in our type 2 diabetic patients. To conclude, type 2 diabetes is progressive in nature. Timely insulin intensification and continuous follow-up is necessary so that patients should remain in target to avoid future micro and macrovascular complication. Indian reality of diabetes management actually demands simplicity, convenience, so that physicians can intensify and they should improve quality of life. Of all the options available, basal bolus might be a theoretical gold standard, but in real world, we need simple solutions. So insulin co-formulation, premixed insulin therapy, or combinations of basal insulin with GLP-1 RA are actually now suited combinations for intensification of insulin therapy. Thank you very much.